Hi everybody, it's Dr. Paw, your friendly neighborhood obstetrician again. Today we're going to be learning about physiologic changes that occur in a pregnant person. Prior to this session, you've learned about the diagnosis of pregnancy and routine prenatal care. In an attempt to keep this podcast concise and as short as possible, I'm afraid that it's a little bit more dry than I like. But we're going to play a physiology Jeopardy in 273 together to review things again, and I think it's going to be a little bit more interactive and fun. As with a lot of medicine, as you're learning, we can't teach you everything. There's a great deal more to learn, and the maternal physiology chapter in Hacker and More textbook will give you more details if you'd like to learn more. I've tried to distill the basics that I think any practicing physician should know about in this podcast. In this podcast, I'm going to highlight the most pertinent changes that occur in pregnancy that will lay some foundation for you to scaffold more knowledge as our pregnancy material progresses. At the end of this podcast, you should be able to identify key physiologic adaptations of pregnancy, including effect on common laboratory tests, highlight common symptoms of pregnancy that result from these changes, and lastly, differentiate normal changes in pregnancy from pathologic changes and those that impart increased risk to the pregnant person. You'll note that there are different colors here. These colors correspond to where these objectives are highlighted in the podcast. It'll make more sense as you go along. Yellow is when the change is physiologic and is normal or healthy. Blue corresponds to a commonly experienced symptom related to that physiologic change, and red correlates to something that may signal a pathology or impart increased risk. Pregnancy is more than just a growing belly. Pregnant physiology must adapt to meet demands of the pregnancy, and virtually every single organ system is involved. It's important to have an understanding of changes in pregnancy because it impacts how common lab tests are interpreted, how medications may be dosed, or how diseases may vary in their presentation. We also need to understand what changes may be expected to reassure somebody who could be experiencing very normal physiologic changes, but these are new to them, or when changes are not expected and may be representing an underlying pathology. Blood volume increases by 40% in pregnancy, which means that there is an extra 1 to 2 liters of volume. This is mostly due to sodium and water retention to increase total body water. This can be a problem for patients with restrictive cardiac lesions. Recall that cardiac output is heart rate times stroke volume. Cardiac output increases by 40% by 20 to 24 weeks due to both increases in the heart rate and stroke volume. There is also more blood flow to the uterus itself, which is why somebody can lose a lot of blood very, very quickly during their delivery. Blood pressure for most healthy pregnant people decreases in the first and second trimesters and reaches a nadir mid-pregnancy, and then starts to rise to pre-pregnancy levels in the third trimester. High blood pressure is not normal ever in pregnancy, and you will learn about hypertensive conditions in pregnancy in 274. Blood pressure is low in general in pregnancy because there is decreased systemic vascular resistance due to the progesterone effect, and the placenta also acts as a low pressure circuit. A common symptom experienced by many people due to these cardiovascular changes is supine or postural hypotensive syndrome, also known as aortocaval compression. In a supine position, when the person is lying on their back, the enlarging uterus compresses on the inferior vena cava, causing decreased venous return and cardiac output. If this happens, then they become dizzy, and there can be a temporary bradycardia. This is why pregnant people over 20 weeks should avoid lying flat on their back at home or in the hospital. Sometimes this also happens if they're standing for a prolonged period of time, as the blood tends to pool in the venous system, and so we often recommend compression stockings. In pregnancy, the diaphragm rises, the chest widens, and the ribs flare. Functional residual capacity decreases, and total oxygen consumption increases by 15 to 20%. Minute ventilation increases, and the tidal volume increases. The most important thing to remember, though, is that vital capacity, respiratory rate, and airway function are unchanged. So, if the respiratory rate is increased in a pregnant person, you need to consider other causes. Because the increase in minute ventilation is greater than the increase in oxygen consumption, this leads to hyperventilation in pregnancy and a compensated respiratory alkalosis. This is compensated by increased renal excretion of bicarbonate. This means that the arterial pH of 7.4 is normal in a healthy pregnant person. Many pregnant people feel short of breath and feel like it's harder to breathe sometimes, assuming that there's no cardiac or respiratory red flags and no concerning symptoms that would suggest an infection, heart failure, or a pulmonary embolus. Then it's likely dyspnea of pregnancy, which is common. This likely occurs due to normal hyperventilation that I just mentioned, in addition to the changes of the diaphragm. Feel free to pause the podcast here to review in your own time. I don't expect you to memorize these numbers, but you should have an appreciation of how respiratory physiology changes or does not change in pregnancy. Recall that there is sodium and water retention, increased water and blood volume. This is why pregnant people complain about edema to their hands and feet, and it's so common, and why compression stockings can be helpful. Red blood cell volume does increase, but the disproportionate increase in red blood cells is less than the increase of plasma. This causes a hemodilution and a physiologic anemia of pregnancy, where it's common to see a mild normocytic anemia. However, iron deficiency is also common in pregnancy due to increased demand, and so it can be common to see a microcytic anemia due to low iron in some. A healthy pregnant person with no infection will commonly have a white blood cell count that is slightly increased, and in the absence of any signs or symptoms of infection, can be reassured that this is normal. However, if the WBC is quite elevated, so over 20, for example, or if there's a lot of immature forms, then you would have to investigate appropriately. It's common to see a mild thrombocytopenia in pregnancy as well, but if platelets are under 100, then other things like ITP or preeclampsia should be ruled out. Pregnancy is a prothrombotic state. I cannot emphasize this enough. If you think about it though, physiologic mechanisms to reduce excessive bleeding at the time of delivery make sense. The higher estrogen in pregnancy increases coagulation factors. There is also a decrease of anticoagulation factors like protein C and S. These are the reasons why the greatest lifetime risk of a DVT or a PE is when somebody is pregnant or postpartum. If you suspect that a pregnant person has a DVT, there is limited use in a D-dimer because it's often elevated in a healthy pregnant person at baseline. There is increased renal perfusion and GFR is increased by 50%. This causes hyperfiltration and a decrease in creatinine. Because of these changes, some medication doses need to be increased in pregnancy based on serum drug levels, and a creatinine over 75 should be considered abnormal in a pregnant patient and warrants investigation. It's also common to see a very mild hyponatremia, although most will have a sodium in the normal range. But if the sodium is very low, then they should be investigated. You're going to learn later in the pregnancy materials that proteinuria can be pathologic in somebody who has high blood pressure in pregnancy. But a trace or low amount of protein is normal in the urine due to hyperfiltration. Similarly, a little bit of glucose in urine can also be normal and is usually not significant and should not be used to diagnose diabetes in pregnancy. Kidney stones are more common in a pregnant person, and it is common to see dilated ureters or dilated renal pelvis in a healthy asymptomatic pregnant person as well. All these changes can cause increased urinary frequency in pregnancy. Of course, if people have other symptoms of cystitis, then they should be investigated for a UTI, which is also more common in pregnancy. Gingivitis and hypertrophy or a bleeding of the gums called a granuloma is common, likely due to hormonal effect and maybe some irritation. There's a photo of this later on. You will also learn that nausea and vomiting is unfortunately very common in pregnancy, especially in the first trimester due to the HCG effect. Many people also complain about reflux in pregnancy, which is due to lower esophageal tone and increased intra-abdominal pressure. Liver enzymes are in normal range, but note that the ALP is 2 to 3 times higher because it's also made by the placenta, and that's completely normal to see. Pregnancy is a risk factor for gallstones, and that's because the hormones cause decreased gallbladder motility and increased lithogenicity of the bile. Now, if all these annoying changes not enough, hemorrhoids are also so common in pregnancy, and that's because of the increased local venous pressure and compression in the pelvis due to the enlarging uterus. Not surprisingly, many hormonal changes occur in pregnancy. Estrogen is made by both the fetus and the placenta. It helps the uterus develop, promotes secretion of hormone-binding globulins from the liver, increases vascularization, and prepares the breast for lactation. As you've learned in the menstrual cycle material, progesterone is made by the corpus luteum, and the corpus luteum continues to make progesterone until about 6 to 7 weeks pregnant, at which time the placenta takes over production. Progesterone is imperative to maintain a quiet, non-contractile uterus. Estrogen and progesterone are really the reason for most of the physiologic changes that we talk about in this podcast. HCG, also known as the pregnancy hormone, is made by the pregnancy and initially prevents the involution of the corpus luteum so that the corpus luteum continues to make progesterone. HCG rises to its max around 10 weeks and then it starts to decrease, which is also normal. It's likely the reason for nausea and vomiting in pregnancy. Another important hormone is called the human placental lactogen. This is made by the placenta and causes insulin resistance in pregnancy, which ensures that there is adequate glucose available to the fetus. And this is also the reason that diabetes can be increased risk in pregnancy and why we screen for it. Thyroid function also changes to meet the metabolic needs in pregnancy. Thyroid binding globulin, total T4 and total T3 increase, but free T4 and free T3 are unchanged. You should also be aware that there is a physiologic decrease in TSH in the first trimester due to the HCG effect, as we mentioned in the Diagnosis of Pregnancy podcast. And that's because HCG and TSH share a common subunit. Often people with pre-existing hypothyroidism need additional synthroid to be euthyroid. Estrogen causes vascular distension, vascular instability, and proliferation of blood vessels. In general, there is increased blood flow to the skin, which causes spider angiomas, pulmonary erythema, and varicosities and rhinitis. Many pregnant people will also notice increased skin pigmentation and this darkening of the linea nigra on the abdomen and dark pigmentation on the cheeks on the face called chloasma. Stretch marks can also be common, and a really nice perk of pregnancy is thicker hair. Here are some examples of the skin and mouth changes that I just talked about. Pregnant people on average gain 12 kilos in pregnancy. There is exaggerated lower back lordosis and widening and increased mobility of the sacroiliac joints and pubic symphysis in preparation for delivery. These all contribute to pelvic pressure, back and hip pain, and sciatic nerve impingement. If there are red flags such as neurologic deficits and bowel and bladder symptoms, or lower extremity weakness, then these should be investigated just like anybody else. You've also learned about fluid retention and edema of the extremities. Well, this can cause or worsen carpal tunnel syndrome with compression in pregnancy. There's also a lot of gynecologic changes. The uterus hypertrophies. The cervix appears more blue due to increased vascularity. These are completely benign changes. An ectropion of the cervix is due to estrogen, and this is when the cervix pouts out a little bit, as you can see the columnar epithelium. In the photo down below here, the white arrow points at a rim of mild redness at the cervix. This is the ectropion. This can cause benign bleeding, especially after sex. It's also common to see if somebody is on the hormonal contraceptive pill as well. A mucus plug forms in the cervix, and there is generally more mucus made in pregnancy and more vaginal discharge. As long as there's no itch, no odor, it's likely physiologic. If it causes symptoms, then swab should be done to rule out infectious causes. Not surprisingly, there are breast changes. The breasts increase in size and density, but there should never be a palpable mass. If this is noted, it should be investigated, as breast cancer can occur when somebody is pregnant. Tender breasts, however, are common and often benign. As with other skin pigment changes, hormones can increase pigmentation of the nipples, and the areolae enlarge in normal pregnancy. Many pregnant people will notice small little white sebaceous glands on their areola, and these are also normal. Colostrum is a nutrient-rich milk from the breast. It's commonly produced before delivery and is a common cause of benign nipple discharge in the pregnant person. Colostrum can be frozen and collected to feed to the newborn after it's born. If not already reviewed, please proceed to the Prenatal Care for Desired Pregnancy podcast and the Prenatal Screening podcast. And I'll see you again in the next vlog. Thanks for listening.